Welcome to the Deep Dive. We're here to cut through the noise and get straight to the critical, actionable insights you need, especially when every second counts. Today, we're tackling a core topic in emergency medicine, the first 5 minutes, mastering the primary survey in trauma.
Oh, boo.
This deep dive pulls directly from Chapter 1 of the ATLS 11th edition, and it's specifically for you, our emergency medicine residents tuning in. We know your world is high stakes, high pressure, zero room for error. So this isn't just theory. This is about practical, real-world application right there in the trauma bay. Picture this. Maybe you're halfway through a shift. That trauma pager just goes off. Incoming. MVC, high-speed, unhelmeted motorcycle rider, GCS-6, hypotensive, ETA 2 minutes.
Sure.
The specific scenario, that's what we're diving into. Our mission, extracting the absolute must-know, must-do actions from ATLS Chapter 1 for those critical first moments.
Yeah, that's the reality, isn't it? Trauma doesn't really give you time to ease into things. The main goal, fundamentally, is recognizing and treating what kills the patient first. And doing it, immediately. This isn't just about reciting an algorithm A, B, C, D, E for that writer coming in. This deep dive is really about understanding the life-saving mindset behind the whole primary survey. It's about how you approach it.
A life-saving mindset, even before the patient gets there.
Okay.
How does that mindset actually practically change those first 5 minutes for our incoming writer, beyond just, checking off boxes?
Oh, absolutely. That before the patient arrives phase, it's often tragically underestimated. So for a writer unhelmeted hypotensive, that immediately tells you a high energy, probable head injury, likely significant bleeding. That dictates your preparation. First, you assign clear team roles. Who's leading? Who's on airway? Nurses. Scribe. Get it sorted. Then you huddle. You quickly brief the team on expected injuries, potential management plans. You're anticipating severe head injury, a compromised airway, hemorrhagic shock. This pre-arrival huddle, honestly, it's a game changer. You're building that shared mental model before the chaos starts.
Right, so everyone knows the likely threats.
Exactly. And beyond the team, the room and equipment have to be ready. Is the room warm? Hypothermia kills in trauma. Is your airway cart checked? Laryngoscope, tube, suction? And critically, is that surgical airway kit right there at the bedside?
Not down the hall.
Absolutely not. All these supplies large bore IVs, IO kit ready, ultrasound. Your fast machine should be plugged in and ready, pelvic binder, tourniquets, and blood products. For this rider, being hypotensive, you should seriously be considering activating your massive transfusion protocol before he even hits the door.
Wow, okay. That proactive.
Yes. And of course, PPE. Everyone needs gloves, gowns, eye protection, masks. Non-negotiable. Infection risk, hazard risk. It's all about anticipating, not just reacting.
Okay, that's powerful. So team briefed, room ready, everyone suited up, ambulance doors swing open, riders on the stretcher. Let's walk through it like we're right there. Cool head, focused team, zero wasted motion, and that core principle driving everything. Treat first what kills first.
Precisely. And just remember, while we break down X, A, B, C, D, E step by step here, in reality, these things often happen simultaneously. It's dynamic. So first is X, exsanguination, massive external bleeding. For a rider, if he has, say, a traumatic leg amputation or obvious arterial spurting, that takes priority, even over the airway initially.
Stop the bleed.
Stop the bleed. Your action is immediate identification and control, direct pressure, tourniquet high and tight on an extremity, maybe a pelvic binder if you suspect pelvic instability based on mechanism, or a quick check.
That idea of control it, don't just talk about it for bleeding seems simple, but what's the real mental hurdle for residents in that chaos? When the airway seems critical too.
It's the sensory overload, I think.
Yeah.
And that instinct to keep assessing everything else. You see the blood, but your brain is trying to process the GCS, the breathing pattern. The challenge is to force yourself to focus, filter the noise, and physically intervene on that bleed. If blood is pumping out, your hand, a dressing, a tourniquet goes on now. Don't wait for vitals. Don't wait for the full exam. Stop the bleed.
Got it.
Then we move to A, airway with cervical spine protection. Now, for our rider with a GCS of 6, we already know his airway is high risk. But let's say it was less clear. You'd ask, can you speak clearly? If yes, airway's probably okay for the moment. But if the GCS is 8 or less, like our patient, or you see obvious signs, facial burns, blood in the airway, and neck swelling, stridor, facial trauma, smoke inhalation, you secure it. Pronto. Simple options first. Jaw thrust, suction, maybe an OPA or NPA. But usually, definitive airway rapid sequence intubation, RSI, is the way to go in major trauma. A supraglottic airway, like an LMA or iGel, can be a vital bridge if RSI is tough or fails. And surgical airway is your final backup.
The last resort.
The last resort. And crucially, always assume C-spine injury until proven otherwise, especially with this mechanism. Maintain manual inline stabilization throughout any airway maneuvers. Collar, blocks. And once that tube is in, confirmation is key. End tidal, Cohero. ETCO monitoring immediately.
You really emphasize ETCO Euro. Why is that such a critical early measure, especially for our head-injured rider?
Because it gives you real-time data on two critical things: ventilation and perfusion. Breath sounds tell you air is moving, but ETQ2 tells you if you're actually exchanging gas effectively and if there's blood flow carrying CoO back to the lungs. A sudden drop. Could be tube displacement, or worse, impending cardiac arrest. A persistently low reading in a hypotensive patient. Probably poor cardiac output. It's way faster than pulse ox for spotting hypoventilation or apnea, and much quicker than waiting for a chest x-ray to confirm tube placement.
And for the head injury.
For our rider, controlling CURO is vital to prevent secondary brain injury. Too high or too low CUROs affect cerebral blood flow. You can't afford to delay intubation in a head injury with a low GCS. Period.
Okay, makes sense.
Next up is B, breathing. Ventilation and oxygenation. Standard approach. Look, listen, feel. Are they struggling to breathe? Tachypneic, using accessory muscles. Is the SPO low? Any asymmetry in chest rise? Absent breath sounds? Tracheal deviation? You're looking for immediate life threats here. Tension pneumothorax, massive hemothorax, flail chest with pulmonary contusion, an open pneumothorax, a sucking chest wound. These kill fast. Interventions are direct. Needle decompression for tension pneumo. Don't hesitate. Chest tube for a massive hemothorax, a 3-sided occlusive dressing for that open chest wound, and obviously high-flow oxygen for everyone.
Right, and that's where you said, don't wait for imaging. You are the intervention. What's the biggest mistake residents make here when a patient's crashing from a B problem?
Hesitation. It's almost always hesitation. Waiting for that x-ray confirmation when the clinical signs are screaming tension, pneumothorax, and, hypotension, tachycardia, absent breath sounds, JVD, maybe tracheal deviation.
You just do it.
You needle it. Now, midclavicular line, second intercostal space, or anterior axillary line, fifth intercostal space. The x-ray can confirm later, but your needle saves the life. Same urgency applies to massive hemo. Clinical diagnosis first, act fast.
Okay, powerful.
Moving to C, circulation, shock, and bleeding control. For our hypotensive rider, shock and trauma is hemorrhagic shock until proven otherwise. That's your default assumption. It's a clinical diagnosis initially. Tachycardia. Cool, clammy skin, delayed cap refill, maybe altered mental status, weak pulses. And here's the scary part. Blood pressure can stay surprisingly normal until they've lost up to 30% of their blood volume.
30%. So you can't wait for the BP to drop.
Exactly. Don't be fooled by a number. Look at the whole picture. The heart rate, the skin, the mental status. Those are earlier signs. Your immediate actions for C. Get 2 large bore IVs. If you can't get peripheral access quickly, go straight for an IO. Intraosseous access is fast and effective. And start fluids, but think blood first. Balanced transfusion, packed red cells, plasma, platelets, ideally in a 1.1:1 ratio if you're activating massive transfusion. Blood is far better than just pouring in crystalloid.
Right, less crystalloid generally.
Much less. And think about where the bleeding might be hiding. The mnemonic is useful. 1 on the floor and 4 more. So external bleeding, you hopefully controlled an X. Then the 4 internal cavities: chest, abdomen, pelvis, and long bone saucies. Think femurs. Major tissue disruption. For our rider, you need to find the source fast. That's where your adjuncts come in. Fast exam right there at the bedside. Portable chest x-ray, portable pelvis x-ray.
Okay, and fluid strategy. You mentioned blood, but what about targets?
Good question. For most penetrating trauma without a head injury, we practice permissive hypotension. Aim for a MAP around 60, 65, maybe 70 millimilli Hg, just enough to perfuse vital organs without blowing clots off. But for a rider with the GCS of 6, that's different. He needs adequate cerebral perfusion pressure. So you aim for a higher BP target, maybe a MAP closer to 80 or 90 millimilli Hg, depending on local neurocritical care protocols. Avoid aggressive crystalloid resuscitation, definitely. And like we said, strongly consider early MTP activation if he's bleeding and unstable.
So it's a real balancing act there. Keep the pressure low enough for the body, but high enough for the injured brain. That's tricky.
It absolutely is. It requires constant reassessment. Which brings us to D, disability, neurologic status. We know our rider's GCS is 6, but you do a rapid neurocheck anyway. The full GCS, eye-opening, verbal response, motor response. Check pupil size reactivity. Look for any lateralizing sign suggesting focal injury. The rule is pretty clear. If the GCS is dropping or if it's 8 or less, like our guy, you intubate early. Protect that airway, control ventilation, prevent hypoxia and hypercapnia, and get neurosurgery consulted immediately. And here's a critical pearl. Never, ever assume a low GCS in trauma is just from alcohol or drugs. You have to rule out intracranial injury or hypoxia or shock first, protect the brain, assume spinal injury, reassess that GCS frequently. It can change fast.
You mentioned earlier, shock and altered LOC are not diagnoses, they are alarms. Can you expand on the practical implication of that view for a resident? What does it change in their thinking?
It changes the endpoint of their immediate thought process. Instead of stopping at, okay, the patient's in shock, which is just labeling a state, you think, okay, the alarm for shock is ringing. Why? It forces you to immediately hunt for the cause. Is it that pelvic fracture? Is it bleeding in the chest? Is the altered LOC from hypoxia because you lost the airway? Is it a head bleed? Is it the shock itself causing poor brain perfusion? Don't just treat the number or the state. Let the alarm drive your relentless, rapid search for the underlying life threat that needs fixing right now.
That's a great way to frame it.
Okay. And finally, E, exposure and environmental control. Simple but vital. You have to see everything to find all the injuries, cut off all the clothes, then log roll the patient carefully, maintaining spinal precautions to examine the back, spine, flanks, buttocks. But the moment you've done that exposure, you need to think environment. Prevent hypothermia. It's a killer in trauma. Cover the patient immediately with warm blankets. Use fluid warmers for IV fluids and blood products. Keep the trauma bay itself warm.
Yeah, absolutely critical. That links straight into the lethal triad: hypothermia, acidosis, coagulopathy. They feed each other. Warming them early is a direct intervention against that deadly cycle. And, through all this high-tech, fast-paced stuff, remembering to preserve the patient's dignity as much as possible.
Essential.
Okay, so we've run through XABCDE.
Yes.
But you're not working in a vacuum, right? There are adjuncts. What's the biggest trap residents fall into when using adjuncts, especially with someone unstable like our rider?
The biggest trap is letting the adjunct delay a necessary life-saving intervention. Like we said, don't wait for the chest x-ray to needle attention pneumo. Don't delay getting blood up because you're waiting for a type and cross when ONEG is indicated. Adjuncts support your assessment and management. They don't replace your hands or your clinical judgment, especially in the primary survey. Key adjuncts include continuous monitoring, ECG, pulse oximetry, and critically, that ETCO we talked about if they're intubated, blood pressure, cuff cycling frequently, core temperature, maybe urine output later. You have to monitor constantly. If you don't monitor it, you can't manage it.
Right.
Imaging adjuncts at the bedside. Portable chest x-ray, portable pelvis x-ray. Don't send an unstable patient to the scanner. The FAST or EFAST exam is huge, quick look for fluid in the belly, around the heart, in the chest. For our unstable rider, a positive FAST, particularly in the abdomen, probably means a trip straight to the OR. Get surgery involved early.
Okay. What about catheters and tubes?
Urinary catheter helps track urine output, a key sign of end organ perfusion. But hold off if you suspect urethral injury, like blood at the meniscus or a high-riding prostate. Gastric tube, usually an OG tube or axvastric if there's facial trauma, helps decompress the stomach, reducing aspiration risk, especially before intubation if possible. Other interventions that are sort of adjuncts: IVIO access, we mentioned short, wide-bore catheters are best. IO if FAVI is difficult or delayed. Spinal motion restriction collar, maybe temporary backboard for transfers, but get them off the board ASCP to prevent pressure sores. Pelvic stabilization binder or sheet wrap for suspected pelvic fractures in hypotensive patients. And extremity splinting, usually secondary survey, but if you have an obvious femur fracture potentially causing shock, splitting it early can help control bleeding and pain.
Okay, so this whole process sounds incredibly dynamic. Our motorcycle rider could stabilize for a bit, then suddenly deteriorate.
Exactly. That's the nature of trauma. You have to reassess constantly. Vitals, GCS, pupils, peripheral pulses, urine output, everything. A trauma patient is only stable until they're not. And if their condition worsens at any point, you don't just treat the new problem. You go back to the beginning. Repeat the primary survey. Start at X again. What did I miss? What has changed?
Constant vigilance.
Constant. And that constant reevaluation highlights the need for excellent teamwork, clear transfer protocols, and focusing on human care. Trauma is fundamentally a team sport. clear roles, clear communication, and that shared mental model. We talked about those things save lives just as much as technical skill.
Communication tools are key here, then.
Absolutely. The pre-arrival huddle. Using a structured handover like MACE from EMS mechanism, injuries found, signs, symptoms, and vitals, treatments given, and trends. Having quick huddles or check-ins during the resuscitation to make sure everyone's aligned. And if you need to transfer the patient, use a structured handover like SXX CDE bar. Situation, the current XABCDE status, background, your assessment, and your recommendations request.
That brings up a point for you listening. You can't always control the chaos, but you can control your communication. What's maybe the single most vital communication technique a resident can use in that noisy, high-stress trauma bay?
Closed-loop communication. It's simple, but incredibly effective. You give an order clearly, you direct it to a specific person, they confirm they heard it, and then they report back when it's done. Like, Sarah, I need 2 units of ONEG blood, now please. Sarah replies, copy, 2 units ONEG. Then later, okay, 2 units ONEG are infusing. That loop prevents critical tasks from getting dropped in the confusion.
Makes total sense.
And documentation. Document everything clearly and concisely. Get consent if possible. For transfers, make sure all the labs, imaging reports, and any advanced directives go with the patient.
Okay, that's a solid framework. Now, we know not all patients are the same. ATLS points out special populations. Can you briefly touch on key considerations for groups like kids or pregnant patients?
Right, very important. Kids, pediatric trauma, they compensate really well, then crash suddenly. They hide shock signs. Hypovolemia might only show up late as hypotension. They also lose heat much faster due to higher surface area. So keep them warm, be vigilant, and don't rely solely on BP. Look for tachycardia, poor perfusion, altered mental status.
And pregnancy.
Trauma in pregnancy. 2 patients, remember. Pregnancy physiology can mask shock. Their heart rate is normally higher. BP might be lower. The gravid uterus can compress the IVC, so tilt the patient slightly to their left. And hypoxia affects the fetus very quickly, so aggressive airway and oxygenation are key.
Older adults.
Older adults often have less physiological reserve. They don't compensate as well and recover slower. Pre-existing conditions and medications like beta blockers masking tachycardia or anticoagulants worsening bleeding complicate things. Have a lower threshold for suspecting serious injury, especially spinal injury, even from seemingly minor falls.
What about obese patients or athletes?
Obese patients can present technical challenges, difficult airway, hard or fast exams, maybe issues with CT scan or weight limits. Their physiology can be altered too, so be cautious with fluid volumes. Athletes, on the other hand, their excellent conditioning can mask early signs of shock, like tachycardia. Their baseline vitals might be low. So rely more heavily on the mechanism of injury and subtle signs rather than potentially misleading vitals.
It's clear there's a lot of nuance beyond the basic algorithm. And moving beyond the technical, the trauma bay is intense, often involves bad news. How do you handle that human element, delivering difficult news amidst the chaos?
It's incredibly tough, but vital. You need a structured yet compassionate approach. ATLS suggests some model, sometimes remembered by ABCDE. Ask aloud questions. Begin by finding out what they know. Concisely give the medical information. Don't overwhelm with jargon. Elicit emotions and empathize. And end with a clear plan or summary. Basically, organize your thoughts first. Prepare for the meeting if possible. Meet the family, deliver the news clearly but kindly, allow for reactions, answer questions honestly, and ensure they understand the next steps. Then, importantly, debrief with your team afterwards. It builds trust and helps everyone process.
That debrief is crucial for the team's well-being, too.
Absolutely. And thinking bigger picture, trauma care doesn't stop at the ER door. Injury prevention is a huge part of it. The 3 E's education, like helmet use, engineering, safer cars, roads, and enforcement, speed limits, DUI laws. It's a reminder that trauma often isn't just an accident. It's frequently preventable.
Right. A public health perspective.
Exactly. And briefly, good records and legal considerations are part of professional practice. Clear documentation ensures continuity, helps with quality improvement and debriefing, and offers legal protection. Always try to obtain consent and rigorously follow privacy rules like IPEA. So pulling it all together, the main takeaway from ATLS Chapter 1. The primary survey isn't a static checklist. It's a dynamic, systematic, yet flexible process demanding constant vigilance, teamwork, and rapid, decisive action.
So wrapping up this deep dive, the core message really is about urgent, focused action without delay. It's about seamless teamwork, using your tools wisely, constantly reassessing and adopting that life-saving mindset from the second you get that call.
Yeah, I'd say the best trauma care is fast, focused, definitely human, and also humble. You have to recognize the danger instantly, respond without hesitation, but always respect the incredibly vulnerable patient right there in front of you, even amidst the noise and pressure.
Great final thought. For everyone listening, we really encourage you to take these principles, apply them, keep learning, keep refining, stay sharp, and stay human in the controlled chaos of trauma care.